we're going to assume that people have seen the things that you guys had invited me to do about a year ago. Those were 3 separate talks on the overlap of chronic fatigue syndrome and orthostatic intolerance and some COVID material. And I thought what would be useful today was not to repeat all of that, but to really dig into some cases of long COVID that we've worked with to give you a sense of how this unfolds and what kinds of things you can try to do. So I don't have anything to disclose. And to start with, we still don't have any consensus on the definition of what long COVID is. And this leads to a lot of variability in what people talk about. The CDC describes several post-COVID conditions, meaning that these are things that persist for at least a month. And some of them are understandable. So they're the multi-organ and autoimmune effects of a severe COVID infection, including MIS-C in children. We know that if you get intubated and you're in an ICU for a couple of weeks, that many people will get a post-ICU syndrome characterized by fatigue, tachycardia, brain fog, and so on, lasting many months. But I think what has captured people's interest is the third item on this list, which is new or persistent symptoms after relatively mild or sometimes asymptomatic disease. So I'll be focusing on that aspect of long COVID today. The WHO has a slightly different definition of long COVID. They refer to individuals who have a history of probable or confirmed SARS-CoV-2 infection. So this includes the people who are early in the pandemic when we didn't have adequate testing available. And they insist that it begin within 3 months from the onset of the initial infection with symptoms that last for 2 months and can't be explained by an alternative diagnosis. That's a bit ambiguous. The common symptoms are fatigue, shortness of breath, and cognitive dysfunction, but there are many, many others. And importantly, they insist that these have an impact on everyday functioning. The symptoms can be new following an initial recovery from the COVID infection, or they can be persistent from the very beginning. And then symptoms can also fluctuate or relapse over time, often after individuals exceed their normal limits of exertion, either cognitive or physical exertion, or sometimes after orthostatic stress. So depending on which one you use to apply to your patients, you can get different estimates of the prevalence of long COVID. The form that has interested us the most is when those symptoms meet the criteria after 6 months for myalgic encephalomyelitis chronic fatigue syndrome, or ME/CFS. And I was on the Institute of Medicine committee in 2014 that reviewed the literature on this illness and tried to come up with a simpler definition, case definition. And we insisted that patients have these core symptoms. One was a substantial impairment in the activities the person tolerated before the illness. And that was almost always accompanied by profound fatigue, but it placed the emphasis more on impairment than on the single symptom of being tired. Patients had to have post-exertional malaise, which refers to this increase in a variety of symptoms, not just fatigue, after they've exceeded their limits of physical or cognitive exertion or orthostatic stress, as we've found subsequently. Patients had to have unrefreshing sleep. Those were the core symptoms, and either cognitive impairment or orthostatic intolerance, which refers to symptoms that get worse with quiet upright posture, both sitting and standing, and are generally ameliorated by recumbent posture. The committee insisted that the symptoms be present for at least 6 months, and that gets rid of a lot of post-viral symptoms, for example, after flu or EBV, and I think after COVID as well, that don't need treatment. They're going to resolve spontaneously. Symptoms have to be present at least half the time and have at least moderate severity. The feature that we find to be most treatable is that of orthostatic intolerance. And this diagram is meant to give you a review of the physiology of orthostatic intolerance. These are patients who for some reason when they're standing have increased pooling of blood in the dependent circulation, possibly due to a defect in their ability to vasoconstrict, and that can have several different causes. They also have about a 10% reduction in intravascular volume that can be measured using fancy nuclear medicine tests, but they're really expensive, $3,000 or $4,000 per test, so they're not clinically available anymore. But these are symmetrical reductions in plasma and red cells, so you can't pick them up looking at a hematocrit or at their creatinine. The combination of those two factors means that when people stand, they have a reduction in brain blood flow. That elicits a big sympathoadrenal response in the autonomic nervous system. And then the phenotype, circulatory phenotype you get can be orthostatic hypotension, which requires a 20 millimeter of mercury drop in systolic or 10 in diastolic pressure in the first 3 minutes upright, or delayed orthostatic hypotension, which means the same drop in pressure after the 3-minute point. Something we call neurally mediated hypotension. This is the same physiology as vasovagal syncope, but not all of the patients have been syncopal in day-to-day life. So we call it NMH for short. Postural tachycardia syndrome, which in individuals under 20 requires a 40-beat increase in heart rate in the first 10 minutes of standing. And then we've recognized that there are many patients who don't have any of these heart rate or blood pressure changes, but still have a big reduction in brain blood flow and might have, and still have low orthostatic tolerance. So these are the people with a normal heart rate and blood pressure. And so to treat this problem, you can use vasoconstrictors, and we'll go over which ones you can try later, volume expanders, and then drugs that can affect heart rate or catecholamine release or effect. So we published a small case series in 2021 to draw attention to the fact that adolescents and young adults who had confirmed or probable COVID-19 infection could go on to have persistent symptoms. And these were people who had been working or studying full-time before they got sick. 2 of the 3 had confirmed infections. 1 had a very likely infection but wasn't tested. And they all met the Institute of Medicine criteria after 6 months of illness and continued to meet criteria for longer. And I thought what might be helpful tonight is to focus in on one of these patients. It's a 19-year-old. This young guy had allergies to pollens and grasses that were bad enough that his pediatrician sent him for immunotherapy between the ages of 10 and 13. He still has oral allergy syndrome after exposure to carrots, cashews, and cherries. And he had mild asthma, but this was well enough controlled that as a Hopkins University freshman, the year in 2019, he could run 60 to 70 miles a week as part of the routine cross-country team training. So he was really quite fit. He lives in Florida, and he was back visiting his parents and was exposed to a relative with COVID. And he developed a number of respiratory symptoms that we're familiar with at this point: cough, sore throat, headache. He was quite tired. He had a lot of flu-like achiness, and his PCR test was positive within the next couple of days. He did have some anosmia for a few months, but really wasn't very sick with this. He was never hypoxic, didn't need hospitalization. And as the flu-like symptoms started to lift after 2 weeks, he noticed that his heart rate was quite elevated walking between rooms of the house. 2 months after the illness, one event stuck out, and that was they were playing a game of cornhole in the backyard. And I think everybody knows what that is, but it's a beanbag toss that really requires very little physical exertion. And with that, his heart rate peaked at 170 beats per minute for about 30 minutes. And he had 3 days of being in bed as a result of this level of minimal exertion. His cardiologist did a number of tests that ruled out ischemic change, and he looked pretty normal. But at the 3-month point, his big symptoms were familiar from that Institute of Medicine list: fatigue, trouble with sleep, unrefreshing sleep, post-exertional malaise, lightheadedness, some mild cognitive dysfunction. And he had this new sense that things were overwhelming for him. Like when he went to the shopping mall, it was just too much. and he'd never been anxious or had that problem before. We asked him how would he rate his wellness, and we find this to be a very useful little scale to follow in patients. 0 means you're dying. 100 is as good as you could imagine feeling. And at this point, here's this guy that could run 60, 70 miles a week and probably had a wellness score of 100 before he got sick. He's down to 45, so a big impairment in function. His examination, when we saw him at the 3-month point, showed a Basin score, which we use as a screen for joint hypermobility, and that was a score of 3. You need a score of 4 or higher to meet criteria for hypermobility, but he was a little flexible. He had some neurologic abnormalities with a positive Hoffman sign, which you can elicit by flicking the middle finger, and you're looking for an involuntary flexion of the fingers. And neurosurgeons refer to this as the Babinski of the upper limb. Often it's associated with cervical spinal abnormalities like bulging discs or stenosis. And he was a bit tight on some physical therapy screening tests that we use, like a passive straight leg raise. We've all done that looking for meningitis. He could only get to 30 degrees on this test before he wanted us to stop. We tested him for a number of things that we do in pediatrics for failure to thrive and when people aren't functioning well, and you guys know that workup. We also added a plasma histamine level, which was above twice the upper limit of normal, and that was to investigate his problems with allergies, and in part the speculation that mast cell activation is part of the pathophysiology of some of these post-COVID conditions. And we confirmed this on 4 different occasions that he's had persistent elevations. The other thing that was quite abnormal in this young man was that even though his resting heart rate was 59 supine, when we stood him up leaning against the wall, his shoulders against the wall, his heart rate kept going up and reached a heart rate of 129. So he more than doubled his heart rate just standing still in the office. And that provoked some of his symptoms like headache. Now, even though this was 3 months after the onset of the illness, he hadn't been completely inactive. We don't think this was from deconditioning because his heart rate had been high from the beginning. When we look at orthostatic intolerance like POTS and it's leading to ME/CFS, we also look for a variety of conditions around this wheel. So people can get a secondary anxiety or depression because they're just not functioning well. We can see motility disturbances, reflux, irritable bowel syndrome. About a third of our patients can have a delayed reaction to milk protein, and we look for that by asking about epigastric pain, reflux, and early satiety. Some of those patients also have recurrent aphthous ulcers in the oropharynx. Many of these patients have allergies like this young man did. Infection will aggravate orthostatic intolerance. They can feel tight on these range of motion maneuvers. They'll have headaches and chronic daily headaches. Some have hyperhidrosis as a reflection of autonomic dysfunction. There are occasional patients who have neuroanatomic crowding. About 2/3 of our patients have joint hypermobility as a risk factor for the orthostatic intolerance, maybe because their vessels are a bit stretchy, and when they stand up and get a big column of blood coming down and pushing outward on the vessels, they can pool more blood distally. And then less so in pediatrics, more so in young adults, we can see pelvic vein incompetence and May-Thurner syndrome, where you get compression of the left common iliac vein by the artery above it. So this can be a mixed bag in any one patient, and you have to look carefully. And I think generalists are in a great position to screen for these problems. This young guy had the ones you see in green. So we decided we'd focus our treatment on the allergy type problems, the mast cell activation syndrome that it seemed like he had with the high histamine, a little bit on the anxiety and on the tightness in his neuromuscular exam. So when we treat orthostatic intolerance, these are the 3 classes of medications we can use. And pediatricians actually know a fair number of these. Some of you will be familiar with midodrine, which is an alpha agonist vasoconstrictor. So that can overcome this vasoconstriction defect that many of the patients have. The disadvantage with midodrine is it needs to be given every 4 hours while people are awake. So it's a bit fiddly to get good compliance with that. In contrast, any of the stimulants that you all use for attention deficit disorder are very good as vasoconstrictors, and they have the advantage of having long-acting forms. So you can give one dose in the morning and be done for the day. Some of the SSRI and SNRI drugs have some vasoconstricting properties as well. L-DOPS or droxidopa usually isn't available to us in pediatrics. That's available for adults with orthostatic hypotension. In terms of volume expanders, we encourage all of the patients to increase their sodium and fluid intake, sometimes supplementing that with occasional boluses of saline or Ringer's lactate. And I'll often reserve that for when they're really not doing well with any of the medications, and there's a big family event that they need to attend, like a wedding or a graduation, and you can give them a liter or two of saline beforehand, and that helps them tolerate the upright activity. The main medication as a volume expander is Florinef or fludrocortisone. We use some desmopressin, but you have to watch that if you're using that, you might see hyponatremia. Clonidine can be helpful, somewhat paradoxically, but this expands blood volume. And then for girls who are having lots of fatigue and problems with their periods, birth control pills can be a way to do volume expansion and also address their menstrual dysfunction. The mainstays for reducing heart rate are the beta blockers and pyridostigmine, but there's a newer drug, ivabradine, that can be helpful if heart rate is above 100 at rest. So how did we select these for this young guy? Well, here's a graph of the timeline when we saw him in September of 2020 up to the most recent follow-up, which was just last week. So we initially tried him on midodrine, the M there that you see as a vasoconstrictor. He didn't tolerate that one. Then we added clonidine, and that led to an improvement in his quality of his sleep because we gave it at night. His cognitive function was a bit better, and you guys know that we use this as a second-line drug for attention deficit disorder. But we only could get by with 0.1 milligram daily because anything higher made his fatigue worse. So we had a little bit of improvement from that. We tried adding methylphenidate to the clonidine, and he tolerated just 10 milligrams daily of that. That helped with his cognitive function, but higher doses were associated with insomnia. So he was pretty sensitive to these medications. And we discontinued that once he started to improve. We tried Florinef, which is in the F. He didn't tolerate that one. That led to increased fatigue. And then at the top, you see some drugs for heart rate control. The A stands for atenolol, a beta blocker, the I for ivabradine, and the P for pyridostigmine bromide. Those were quite short-lived and associated with side effects, usually increased fatigue. So it's pretty obvious when he wasn't tolerating anything. So we think we got a little bit of a boost from the methylphenidate and the clonidine. Then we moved over to try and address his mast cell activation. And this is a nice review paper from Theoharides in 2015, pointing out that mast cells can be triggered to activate and degranulate and release all of their contents by allergens, but also by virtually any kind of infectious agent. And that's part of their role in the body, in the immune system. They sit in the skin, the airway, the GI tract, and the interface between nerves and blood vessels as a sentinel that releases contents when they see a foreign invader. And depending on which interleukins and cytokines and other factors are released, you can get a whole range of symptoms that mimic everything you can see with long COVID. So you can get fatigue, you can get the respiratory symptoms, you can get anxiety, depression, brain fog, sleep problems, headaches, bony pain, virtually any kind of GI upset. And we recognize this most readily when the kids come in with a lot of facial flushing, red ears, red nose, blotchy rashes in the upper chest, or hives or itching. So you want to take those into account and especially be aware of the prior allergy history. And then because of the amount of histamine that's released by the mast cells when they're activated, you can see all of the features of orthostatic intolerance, including syncope, presyncope, lots of lightheadedness, and even postural tachycardia syndrome as a manifestation of mast cell activation. So if we suspect that, the treatments are actually fairly benign. You want to avoid the triggers of mast cell activation, which can include specific foods. These patients do not tolerate things like fermented foods or aged cheeses or smoked meats. And in Hawaii, you might have to watch carefully for the amount of histamine in fish. Some of the patients will be so sensitive to histamine in foods that they can't even tolerate leftovers. And I had a patient recently, a young adult patient, whose husband thought she was just becoming a bougie. She'd grown up poor and she couldn't tolerate leftovers. And he thought she was just developing, champagne tastes. But in fact, she was reacting to the histamine that's produced if you put leftovers in the fridge overnight. Certain drugs can activate mast cells, including the opiates. And then the mast cells can be driven upwards by mold, especially in rainy climates or where you've had leaks in the pipes, or other allergens. So we look carefully for whether they tolerate milk or gluten, and some patients can be put on at least a partial low histamine diet that avoids some of the foods that are very high in histamine or capable of triggering mast cell degranulation. We use a lot of the H1 antihistamines, including the old-fashioned ones like cyproheptadine, and we know that that one's a good one for getting people to sleep at night, so sometimes it helps with getting over the insomnia. It also is pretty good for migraine prevention. So it has three potential uses here, including the antihistamine function. You can also use the non-sedating antihistamines or some of the tricyclic antidepressants. They can have quite a strong antihistamine function, doxepin being the most effective of those. The other way of blocking the histamines that are released by the mast cells is with famotidine or Pepcid. And then some patients need some kind of medication that stabilizes the mast cell membrane. So cromolyn, an old-fashioned drug that we've had around for over 50 years, or the nasal form of cromolyn can be quite helpful, as can montelukast or Singulair, and an over-the-counter supplement like quercetin, which helps the mast cell membrane not be so twitchy. So what did we do in Chris? Well, we tried him on cyproheptadine, that's the C at the bottom, thinking that would help his sleep problems and the histamine elevation, but he just didn't tolerate it. He was too tired on that one. So we stopped it. We then added famotidine, and he has remained on that, 40 milligrams twice daily. He tried loratadine. That seemed a little helpful, but we switched it out to fexofenadine, which he's done better with. We added quercetin since it's cheap and over the counter, and then put him on cromolyn, which really helped a lot. Cromolyn was associated with a nice improvement in his resting heart rate. He would get up to a heart rate of 130 walking around the neighborhood with his elderly parents, elderly meaning they were around my age. And they would do just a quiet walk in the neighborhood, but he was getting a heart rate elevation to 130, so really quite extraordinary. We also thought that he got a bit of benefit from montelukast, but then by October of the last year, he was starting to have some depressed mood, so we took him off the montelukast in case that was contributing. But we layered these medicines one on top of the other since they work by different mechanisms. And then we tried two others. One was the escitalopram, the SSRI, to try and address this sense of anxiety or sensory overstimulation. And then there's a medication, naltrexone, that's been around for a long time, but we use low doses of it in the ME/CFS world. It's pretty benign. It just needs to be compounded. And we use between 1 and 4.5 milligrams nightly. And the naltrexone was associated with an improvement in energy and overall function. So here's what happened. At the 1-year follow-up, he was still pretty impaired. He'd been able to, since he got to the 3-month point of the illness, he was able to do online virtual courses, but he struggled a good bit to do that. By the summer, 1 year after the onset, he tolerated a summer internship for 40 hours of virtual work. So that was better. He seemed to have a little bit more oomph. But even a year after the onset, his main symptoms were still fatigue, unrefreshing sleep, and this post-exertional worsening. So he'd get an increase in symptoms if he overdid the amount of walking or his pace of walking. And as I mentioned, walking 15 minutes twice a day, his heart rate would still get up to 130. So we knew that it would be unlikely that he would tolerate any further increases in his physical activity. Fast forward to the 15-month point, and at this point, he was able to go back to campus. He was able to walk around the campus. He was a member of the cross-country team, but all he could do was help with the timing for his teammates. We began him in manual forms of physical therapy because, remember, he had that tightness with his straight leg raise, and they sort of cleared that out. And then they thought he was ready to add some stationary biking. Activity and exercise can be really problematic in patients with long COVID and chronic fatigue syndrome. So you have to really advance very carefully to avoid provoking increased symptoms. If you had put him in a Marine boot camp at this point, he wouldn't have done well. But he was very disciplined. And in September, he did 15 minutes twice a week on the bike. And he did that for a month, realized he could tolerate it, wasn't getting post-exertional malaise. So he went up to 20 minutes 3 times a week for October, a little bit of an increase in November, 25 minutes 4 times a week. That was enough to make him think he was very close to his margin for triggering increased symptoms. So he stayed at that amount for 2 months, then went up to 30 minutes 4 times a week, and continued to improve so that by March of 2022, he was able to run. And he again started this very gradually, 10 minutes every other day. And every week that he did okay, he would go up by 2 minutes. By October, he was able to run again with the cross-country team, and he could do an 8K race. I asked him, how was your time? He said, not good. You know, he's an athlete. He had some pride. And I talked to him last week, and now he's able to do 40 miles a week, but he's practicing with the girls' team. So it's not the same pace or volume as he would do if he was back with the boys' team, but this is a way for him to re-engage with the team, which I think was critical for his mental health. So that, I think, was an example of somebody who we've treated using the principles that we've found helpful for ME/CFS. And while we don't see that level of improvement in everybody, it points out that the treatment involves a lot of trials of different medications, some patience on the part of the patient and the family, but a sense that we should be able to get some traction. Let me present a case that we're early into the process of treating, but to give you a sense of our thought process as we treated this young girl. So this was a 15-year-old. And as you'll see, patients come to COVID with prior problems, prior conditions. So this is a girl who had a history of reflux in infancy that required some acid suppressive treatment. And she had something wrong with either the number of infections she was exposed to or her response to them, as she would get chronic sinus infections until she was about 5. They noticed that she would get a number of symptoms like diarrhea, nausea, vomiting, belly discomfort after consumption of gluten. And she was diagnosed with non-celiac gluten intolerance at 6 years of age. And those GI symptoms improved on a gluten-free diet. She was otherwise pretty healthy until the onset of COVID in January 2022, so just a year ago. And her acute symptoms were very much like the young man I presented earlier. She had extreme fatigue from the outset, some cough and congestion. And she noticed during the acute phase that her resting heart rate was sky high, 150 to 160. I mean, that's sort of bronchiolitis in a baby level. Her resting heart rate had previously been in the 80s. So as she went on, her respiratory symptoms lifted after about a month. But when we saw her at the 9-month point in clinic, she was having fatigue all day, every day. And she would have, after a day of relative increased activity, she would get 24 hours of post-exertional malaise. And remember, that's not just increased fatigue, but it can include increased pain, headaches, brain fog, many of the symptoms that we see after concussions, right? Like lightheadedness and sensory sensitivity. She would need a day to recoup and rest. This is a kid who used to love going to the gym and being active, but as the parents said, fatigue had overcome her life. And she actually counted a wellness score of just 30 out of 100. Remember, our young man before was about a 45 when we first started seeing him. She had a lot of brain fog, and the brain fog in these illnesses can look like somebody suddenly acquired ADHD without the hyperactivity. So she had a lot of difficulty with short-term memory, lots of trouble paying attention and focusing in class, which was frustrating to her as a good student. She had shortness of breath, and there can be an orthostatic dyspnea with these conditions. She would get a shortness of breath with prolonged walking, but wouldn't get chest symptoms when she was lying down or just sitting still. And this was not associated with cough or wheezing, so it wasn't an airway reactivity. It was a sense of air hunger. She would feel a need to take a deep breath to ease that. And in some of the physiologic studies, this shortness of breath or this increased respiratory rate will occur when we're doing a tilt table test and somebody's head up on the tilt table for a while, and you see a reduction in their brain blood flow below a critical threshold. And it seems as if they start breathing deeper and more rapidly to sort of suction more blood back up to the heart. The problem with that is that it works for a cycle or two of heartbeats, but then as you keep breathing faster and more deeply, you're going to hyperventilate, lower your CO2, which then leads to a constriction of the brain blood vessels and worsens the lightheadedness. So it becomes a self-defeating circular process. She was also getting lightheaded, and this is a symptom we search for in all of these patients. Not only that, we want to know how they do in positions of quiet, upright posture. And as you heard from me last year, my real thing that I go after is how do you do when you go to the shopping mall? And if you've got an adolescent who can't go to the mall, you've got an organic problem until proven otherwise. These guys don't do well with quiet ambulation. So they're very uncomfortable standing in church, standing in line at the store, going to the mall, or going to a museum. So she would get visual dimming when she would stand too quickly and often had to hang on to the wall. She would then go to the ground and feel like she was going to faint, but had enough warning that she hadn't actually fainted. One of the other situations in which lightheadedness can be provoked is in a hot environment. You guys would see that based on your climate in Hawaii, but we will see it more often after a hot shower. So any hot bath, hot shower, hot tub, these guys don't tolerate that very well. They often endorse sitting with their knees to the chest. That's a way of getting blood from pooling in the legs, and it squeezes the blood out of the abdomen. And when I mentioned in our teaching sessions to the families that position is something that is adaptive for those with orthostatic intolerance, the young adolescent girls usually glare over at the parents and say, "See, I told you," because they've often had a fight about the proper way to sit at the dining room table. These patients will stand with their legs crossed over one another to improve muscular pumping of blood up from the legs. They don't know why they're doing it, but they often do that, or they fidget. She's had heart racing during prolonged walking, or if she's overheated. And her resting heart rate on the Apple Watch is usually a 90, but can go up to 160 just sitting there. Her cardiologist had done an echo and EKG that were normal. And she was having some tremors. We sometimes will see these if high levels of catecholamines are present as a part of the response to the lack of blood flow to the brain. And so she noticed that the tremors were more common if her heart rate was elevated or when she was lightheaded. Family history was interesting. Her mother had had endometriosis requiring a hysterectomy at 39, along with fatigue, headaches, and many of the symptoms of her daughter, but mild enough for her to function pretty well. And we had already seen the 18-year-old sister in the family. She has Ehlers-Danlos syndrome, this connective tissue laxity, lots of heavy menstrual bleeding, a lot of allergies, some anxiety and depression. She met the criteria for ME/CFS. She had orthostatic intolerance. She also had mast cell activation syndrome. Many of the patients who have loose joints also have TMJ dysfunction that can contribute to not only jaw pain, but also headaches. And she had confirmed craniocervical ligament laxity, craniocervical instability. So she was getting physical therapy for that. A younger sister had migraines, as did the father. So when we saw her, she had some daily nausea that would get better by the late afternoon, but she'd had a lot of vomiting after COVID, up to multiple times a day, and had lost 40 pounds. And so on her GI study, she had gastroparesis. Erythromycin was started, and that led to improvement in the vomiting. She often had these features that we associated with the mast cell activation, where her face was flushed. She would feel hot 1 second, cold the next, but she didn't have any other redness, hives, or rashes. And some of the patients with fatigue have a sense that their legs are weak and that they can't count on them. That was a little bit unusual, but she felt that her legs weren't there. And then this was a happy girl who had progressive anxiety and depression since the onset of COVID. She had lots of nail biting, and in the adolescents, we always give them a Beck depression inventory. You might use different depression screens, and I think that's because adolescents can present pretty well in person, but might have a lot going on at an affective level under the surface, and this was consistent with moderate depression. When we examined her, she was alert and well-nourished. Heart rate at rest, though, was elevated for a 15-year-old at 105. She was not like her sister. She didn't have an elevated Beighton score consistent with hypermobility. Her reflexes were fine. We do a test. We look a lot for thoracic outlet syndrome, where you're getting compression of the nerves as they leave the neck and go down into the arm. And sometimes their pectoralis muscles can be tender to palpation, even very light palpation. So we do this elevated arm stress test where their arms are at a 90-degree hands up sort of angle, and their hands are opened and closed. And the typical test is for 3 minutes. And people are usually asymptomatic if they're perfectly healthy. But with this test, her arm fatigue occurred at 20 seconds, and she had a hard time keeping her arms elevated by 35 seconds, and her heart rate started going up at 55. So this gave us another thing that we look for in our ME/CFS patients that we might be able to treat, not with medications, but with physical therapy. We also did a standing test in her like we do in anyone with this degree of fatigue. And you can see that with the heart rate in black and the blood pressures in the dotted blue lines, as soon as she stood up, she shot well up above 100, peaking at about 130. She had shortness of breath, lightheadedness, warmth, and increased fatigue. So again, this provocation of symptoms is really practically quite important. It tells you how much the orthostatic intolerance might be contributing to their overall symptoms. So when we made our problem formulation list, we said, okay, she's got POTS. She meets the criteria for ME/CFS based on her impairment in function, her unrefreshing sleep, her post-exertional malaise, the brain fog, and the orthostatic intolerance. She also had the gastroparesis. She had food allergies and seasonal allergies, the gluten sensitivity, anxiety and depression, possible mast cell activation explaining the flushing, and possible neurogenic thoracic outlet syndrome. So it's a big mix, and the challenge in primary care for you all is how do you deal with all of these in one visit? And you probably can't. You need to break it up into several visits. And back to that circle that I showed you before, her mixed symptoms were a little bit different than the other patients, and that's how it goes with these illnesses. So what did we do? Well, we said, all right, you've got the orthostatic intolerance. Let's bump your salt and fluid intake. And for the rashes and the mast cell symptoms and the allergies, let's put you on levocetirizine or Xyzal, 5 milligrams a day. We thought, and the parents thought, that the depression was the biggest factor for her at that time. And she was biting her nails down to the quick. I mean, she was really a big nail biter. So we thought the sertraline might help with a number of symptoms. And we sent her to the physical therapist for these areas of restricted range of motion. So how did she do? Well, at the 1-month follow-up, she was feeling a little better. Her heart rate elevations weren't as extreme when she was upright, but mood was still not where it had been. She was drinking a decent volume of fluids. Facial flushing was still pretty prominent, and we saw that on the telemedicine views. So we doubled her H1 antihistamine, and we also increased the sertraline to deal with her mood, going from 25 up to 50. And we said, let's see you back in another month. At the 2-month follow-up, she was struggling, but still got through to full normal attendance and was achieving A grades. She was sleeping a good 12 hours per night, though, increased from pre-COVID. Very slow to get going in the morning on school days. And her main symptoms were still fatigue, brain fog, and the mood was still not optimal. She was getting lightheadedness and headaches daily and had some diarrhea. But the wellness score is up from 30 when we started to 65. Her mood was better on the higher dose of sertraline. She wasn't crying as much, still had some moments of feeling sad that could last a couple of days, so it wasn't optimal. She had stabilized her weight. She was being seen by a group of gastroenterologists at the Children's Hospital of Philadelphia, and they thought that she just had some mild mucosal changes. And at this point, she still had episodes of feeling shaky and hot and tachycardic. So we thought we might not have reached the optimal sertraline dose, so let's push her to 75 a day. We added some nasal cromolyn, nasal chrome, for the nasal mucosal bogginess on examination and for some of the mast cell symptoms. And we switched from a proton pump inhibitor, which doesn't affect mast cells, over to the famotidine, that is an H2 blocker. And we were going to consider adding atenolol for the orthostatic intolerance as a next step. Other options for the orthostatic intolerance might include the drugs you see at the bottom. So at the 3-month follow-up, she was still having heart rates up to as much as 130 beats per minute at rest. So we added atenolol at that point, and we're waiting to hear back from her. But with that level of heart rate, you've got a number of other options for managing things, and these might be the medicines that we'll try in the future if we're not bringing her in better control with the atenolol. So that's an example of the way we've been approaching things. I'm going to stop there and then let Summer lead you through the post-test questions. Summer, or Anna, are they voting on these? You're muted.
I can't hear you.
Yep. Sorry, I'm going to launch it right now. So I titled it incorrectly. It's titled Untitled Poll, but there it is.
Untitled poll works for me.
Okay.
And we do have a few questions coming in through the chat as well. The first question was in relation to the first case. If this was COVID before having received a vaccine or afterwards.
The first case happened before the vaccines were available. But, you know, it's interesting. We've seen a couple of patients who have developed POTS and prolonged symptoms after getting the vaccine. That doesn't mean we're anti-vaccine. It just means that we have to be aware that that's a potential trigger, and to remind patients that the risk of long COVID or POTS after natural infection is considerably higher by a factor of about 10 than getting it after the vaccine. So we still think the vaccines are protective, but they're not. I think we have to be careful with our use of the terms that we use about vaccines. When people hear that we say they're safe, what we don't mean is that they're entirely safe, that there are some risks, but you have to balance those with the potential benefits. All right, so should we go through the answers? Or
We're just about at 20% completion, so maybe give them a little bit more time, a minute or so. Yeah.
I'm being slow to read myself today, I have to admit. And we do have one other question in the meantime. Dr. Ray was asking if you could discuss the rationale for using erythromycin for the GI symptoms in the second case.
yeah, so erythromycin, I don't know if any of you remember this, but when I was running the walk-in clinics as a resident, we get kids with mycoplasma pneumonia. We treated them in that era with erythromycin. And the mothers in East Baltimore would come back the next night and say, I'd rather have the mycoplasma, thank you very much. My child has too much abdominal pain and cramping. And over time, people figured out that erythromycin binds to the motilin receptor in the gut and causes a lot of GI muscle contraction. So it's had a sort of second coming as a drug for gastroparesis and motility disturbances. So you give it in low doses before meals, and it can be quite helpful for the gastroparesis and motility.
Great, thank you. And they've had a few minutes now, so you can go over the answers. I think you're good. Oh, over 50%. So we're good. Thank you. Stop the poll.
Yeah, so of the tests, the tests that are least likely to be informative in pediatric long COVID, the correct answer is the one that you guys got, the EEG. You know, the others can be informative. The 10-minute passive standing test or the head up tilt test are helpful as you see the symptoms provoked and you see what their heart rate and blood pressure do. And the ECG and echo can be helpful. We don't do an echo in everybody, so that's some of you listed that as an answer, and I would agree with that. In terms of the second one, to diagnose POTS, you need at least a 40 beat increase in the heart rate. If you use the adult heart rate increment of 30, 44% of healthy kids will have a higher than 30 beat increase in heart rate. So we would way overdiagnose people with POTS. The 45 or higher would probably be a bit too restrictive with regard to POTS. So it's a 40 beat increase. And then which of the following is not considered necessary for the diagnosis of ME/CFS according to the Institute of Medicine? You need to have post-exertional malaise, unrefreshing sleep, and orthostatic intolerance. Tender glands was part of the definition, the chronic fatigue syndrome definition from 1994 from Fukuda and colleagues, but that has been dropped because it's not particularly sensitive for chronic fatigue syndrome. And then the CDC definition of long COVID requires a 3-month duration, marked impairment in function, any returning or ongoing symptoms persisting 4 weeks. I can't read the full question there. I think it's the symptoms that persist beyond 4 weeks. The WHO requires an impairment in function. And the WHO definition is a 3-month duration, but practically speaking, I think most of us think of long COVID in the kids who have really prolonged several months of symptoms and a fair impairment in their overall function. All right, I had a couple more slides. Are we okay to go to the resources?
I think so. I think those were all the questions. So resources would be amazing. Thank you.
All right, so this is a primer that we published open access, so you can all download it from Frontiers in Pediatrics. It's about a 40-page document that gives you ideas about dosing for different symptoms like headaches, pain, brain fog, and orthostatic intolerance. And it has sample letters about what accommodations patients with chronic fatigue syndrome might need, and these would be applicable to many of your long COVID patients. The next slide is a paper that a number of us at Hopkins put together looking at the overlap of orthostatic intolerance and ME/CFS. And in here that we had Amanda Morrow and Laura Malone are the physicians that run our pediatric long COVID. Christina Cocorellis runs the pediatric POTS clinic. Lindsay Petracic is a patient in my clinic who really helped a lot with the writing. Ella Easton is an NCAA athlete who won the 400 individual medley 4 years in a row before she got long COVID and POTS. She's now a medical student at Stanford, interested in these autonomic disorders. Katie Lobner was the librarian, and Louise Neuendorf is a physician working on autonomic dysfunction in Toronto. These are a few resources on long COVID that you can take a look at. Some of them have things on POTS. We did a chapter in the Principles and Practice of Pediatric Infectious Diseases, the Sarah Long text, if you want to read more about ME/CFS. Here I've listed a couple of webinars if you wanted to dig more into the practical management of orthostatic intolerance, or to see some other work on different aspects of these illnesses. These are a few of the patient advocacy websites where you can find other talks that might be informative. And most of our work in the last 20 years has been funded by private philanthropy, but it's allowed me to go from a clinic of a one-man band for 20 years to now having 3 of us, including Camille Broussard, who is an adolescent medicine specialist, and Renee Swope, who is a pediatric nurse who has 3 children who are patients in the clinic. So I'm going to stop sharing and then see if other questions have come up.
Thank you so much again, Dr. Rowe. I don't actually see any other questions, so I'll put it out into the group and see if any last minute questions do come up. We have about 3 more minutes that we can borrow of Dr. Rowe's time before everyone else has to get back to their afternoons as well. But in the meantime, thank you so much for joining us again. It was really wonderful to get kind of a 1-year check-in with you and hear how some of these patients have been doing over the last 12 months. One last question did come up, which is, do you treat indefinitely?
So our goal is to use all of these medications and supplements and dietary approaches as a bridge to better health. And the hope is that once they get active again, their autonomic nervous system settles down. But we know over time that it just doesn't magically get better. And I think in the past, the same was the case for ME/CFS. When I started doing this work in the early 90s, often people would say, just wait 2 years, they'll improve. And while there is some spontaneous improvement, at which point you can stop the treatments, many patients just learn to live with it. It's a bit like treating asthma. We don't ever cure it, usually. We just help them manage so that their function is good. Often the corollary to your question, Maria, is, at what point do you try them off the medicines? And with adolescents, they often forget to take them, on an over the weekend trip to somebody's house. And if they're not any worse, they often can tolerate stopping them. Otherwise, you can systematically try stopping them and see if they get symptoms again.
Thank you so much. I think 2 more minutes for maybe the very last question that just popped in, a cardiology related one. I don't know if you can see it yourself, but for younger patients who are physically active, the heart rate will go up and often high, which has been shown to be life preserving. Can you discuss kind of what you've seen with our COVID kiddos?
Yeah, so we expect the heart rate to go up with exercise at any age. It's just, we're looking for whether it's going up excessively and if it's associated with symptoms. That's the key thing, I think, when you're looking at orthostatic intolerance. And remember, there's work from Japan that might be even a bit more relevant to the Hawaii population. The Japanese investigators feel that about 15% of adolescents will have some degree of orthostatic dysregulation. So it's pretty common. It doesn't always need to be treated, but you want to look at whether it leads to impairment in their daily function as your indication for adding therapy. And I would point out that we're not suggesting that we're entirely convinced and confident that everything we threw at the patient that I mentioned earlier worked, right? We can't know how much of this was spontaneous improvement, but each of the interventions seemed to be associated with a nice bump up in his function. And he's been unwilling to stop them since he's been doing so well. So there's a level of uncertainty there. We don't have randomized trial data on all these things either. It's really seat of the pants, practical clinical judgment, which you guys are really good at, I'm sure.
Wonderful, thank you. And it sounds like maybe a reason to invite you back again in the next years to continue to get updates on how these guys are doing and everything new that you're learning.
I'm going to angle for that and keep holding out for when we can actually travel again. So keep my my Chase Lounge on the beach reserved, please.